So as already we have seen that even if patient is stable on ACE inhibitor or ARB and patient have a lower ejection fraction, we should give the benefit of ARNI in all those patients, because already we have mentioned that many of these patients who apparently look stable to us are actually not stable. They have a very high risk of developing sudden cardiac death, ventricular arrhythmias, or in deterioration with a slightest provocation like infection or fluid overload or some salt retention due to some drug interaction. So that shows that actually we should not wait till the deterioration occurs. If the patient can tolerate, we should actually shift them to ARNI to give the maximum benefit. Now doses, as all of us know, it should be started with 50 mg twice daily doses, and after every 2 weeks to 3 weeks time, if the patient tolerates, blood pressure is good, then we should up titrate the dose, and we should try to achieve a target dose of 200 mg twice daily, actually, which is little difficult in our Indian patients. Many of our patients are actually on maximal 100 mg twice daily doses, because 200 mg twice daily dose, many of these patients, they do not tolerate, and they develop symptomatic hypotension or hyperkalemia. So according to the patient's clinical situation, I think we can up titrate the dose, and but we should not, we have to see that even if we can start a 50 mg twice daily dose and patient do not tolerate 100 mg twice daily dose, but we should continue 50 mg twice daily at least, because even if we continue 50 mg twice daily dose, even if we cannot achieve the target dose of 200 mg twice daily, still ARNI is going to give much benefit in this group of patients. Now another important question which usually arises is that this new therapy ARNI can we use in borderline blood pressure, systolic blood pressure patients, because many of the heart failure patients in India, they come with a systolic blood pressure of around 100 to 110. Now whether we can start ARNI in this group of patients is little doubtful, because sometimes we fear that we start ARNI and patient can develop hypotension or can present with hyperkalemia, but it is not so. There were trials which have shown that almost there was a 12% reduction in the cardiovascular event in those patients where ARNI was started even with a borderline blood pressure of 100 to 110. So that shows that even if BP is 100 to 110, we should not deny the use of ARNI, because with ARNI, what happens clinically, even we have seen in many patients that we start ARNI and then after a few weeks the blood pressure starts to increase only, because ARNI causes a sort of reverse remodeling in the heart, and that causes increase in the ejection fraction, increase in the hemodynamics, and that itself actually causes more increased contractility of the heart, and that ultimately leads to a better hemodynamic over time. So that actually shows that if we can introduce ARNI even if with a borderline blood pressure, it doesn't mean that patient is we are harming the patient. Actually we are going to benefit the patient, and in coming weeks you will see that his blood pressure is actually improving only. So that question is being addressed, that definitely we can use ARNI even if in the borderline patients.